Good morning, everyone. I think we're going to start our session, and I expect people will continue to file in over the next little while. Our session is entitled Opening the Door to Antiretroviral Therapy, Tailoring Therapy Across the Treatment Paradigm. So first, we acknowledge the lands and the Indigenous people that this meeting is happening on. We also acknowledge that we come from across the country and acknowledge the peoples and the Indigenous lands across the country. I'm Curtis Cooper. I'm an infectious disease specialist at the U of Ottawa. These are my scientific affiliations, and these are my conflicts, which include a number of pharma companies that I've had the pleasure of working with for years. And this is my colleague.
Good morning. Bonjour, mesdames et messieurs. Pleasure to be here. So my name is Shariq Haider. I'm a professor of medicine at McMaster University, an infectious disease specialist. And you can see my conflicts on the right side. And it's wonderful to see all of you here so early in the morning on a Saturday.
So Shariq and I have both been physicians providing care for people living with HIV for decades now. So we're going to try and share some of our experiences along with talking about the guidelines that are currently out there. And this isn't going to be us reading page after page of guidelines. It's more sort of combining our experience with the experiences of our patients over the years with the knowledge that's embedded in the guidelines. I'd like to acknowledge and thank Merck, who has sponsored this session. So thank you very much for contributing to CAHR and to the academic content. So we're going to talk about the management of HIV/AIDS. We know that therapy consists of multiple antiretrovirals that are used to completely suppress HIV. We're going to review a number of global guidelines for antiretroviral therapy. We're going to talk about a couple of cases which we think illustrate how guidelines can be applied to case management. We'll talk about the benefits and the pitfalls of rapid versus delayed antiretroviral therapy. So we'll review as objectives the first-line antiretroviral therapy. We'll propose guidance on the right approach to antiretroviral initiation for each individual seeking treatment. And we are going to talk a little bit about Doravirine, acknowledging that Merck has contributed to this session. So these are the three guidelines that we've elected to focus on. The NIH guidelines, most recently updated in March of this year. The European AIDS Clinical Society, updated last October. And I've also included some content from the BC Centre for Excellence. A, because it's Canadian, and we need to support each other. And B, because I really like it in that it's a user-friendly document. And again, we're not going to be reading page after page of guidelines. We're going to talk about how these guidelines can be useful for ensuring a basic caliber of care that everybody can benefit from. I remind all my house staff when we're on rounds that guidelines should be a starting point for the practice of medicine. They shouldn't be the final word. These are good. These are help to establish good standard of care, but there's nothing that says that you can't think outside of the box and provide the treatments that are the very best for the patient in front of you, even if it isn't exactly in conformity with the guidelines. So, with initiating antiretroviral therapy, a couple of key things that when I have a patient in front of me, we talk about why are we doing this in the first place? Well, we're trying to convince people to go on antiretrovirals because we know it reduces morbidity and mortality. We've known this for a long time. Okay. When do we start? In the old days, there was a lot of discussion. Should we start immediately? Should we wait until later on in the course of a person's journey with living with HIV? These days, we recommend starting therapy immediately. Now, what does immediately mean? That doesn't mean this very moment. Sometimes it means preparing the patient in front of you for success by addressing some of the other challenges that they face. So maybe immediately means in a couple of months. But we want to get it started as quickly as possible. And this has become feasible for almost everyone because we are blessed with many well-tolerated, safe options for our patients. In the old days when the treatments had lots of problems and multiple pills and multiple dosing periods, sometimes it made sense to delay therapy for people. Okay? And another key point on this slide is that when we're starting therapy, we need to spend time to set people up for success by talking about the importance of adherence to therapy. It's key that if you take the meds, that's going to preserve those treatments and they'll continue to work for people indefinitely. And a key message as an extension of that when I'm having my initial visit with my patient, and I see that as sort of a getting to know each other. You know, this is me, this is what I can offer, and then I try to understand who the patient is in front of me and what their needs and concerns and fears are. And during this conversation, we talk about adherence. Okay? So, the things to consider when starting a therapy, and this is a basic principle of infectious disease practice, is you think about the drug, the bug, and the host. And it's that three-way intersection that will help you to understand why people are successful with whatever therapy you're offering, and it will help you to understand why maybe things aren't working out as well as you'd like. So the drug or the regimen. So how well does the regimen for HIV, how well does it actually work based on the clinical trials? Okay? How likely is it for that regimen to fail because of the development of resistance if there's issues with adherence or absorption? Okay? How well is that medication tolerated? And I think it's fair to say that these days treatments are very well tolerated for most people, but that's still a consideration. And no matter how great a medication is, there's still 5 or 10% of people who might have side effects on any regimen, even with today's options. Okay? What is the potential for drug-drug interactions? And this is a big consideration given the fact that many of our patients are on multiple different medications for other conditions. Okay? The toxicity and long-term safety, and we'll talk about that some more. Pill burden and dosing frequency. You know, as far as when we look back at HIV over the years, the arrival of combination therapy in 96, 97 was one of these, you know, sentinel moments in medicine. And I would suggest that when we started to get the single tablet regimens, that was also a major step forward for what we can offer our patients because it became possible to offer a very simple regimen which opened up the door for therapy for people who just could not be asked to take multiple dosings per day and multiple pills. So that's the drug characteristics. The bug, or the virus, and that all mainly focuses on resistance. Are there existing resistance mutations that are going to diminish the effect of the drug that you're hoping to use? And I'd also add to that list that sometimes you're interested in the different subtype of HIV, and you want to be sure that it's HIV-1 and not HIV-2, because some of our classes, the and NRTIs aren't effective against HIV too, which generally we find in West Africa. Okay? And then, so drug, bug, and host. So lots of characteristics that I think we're all very well aware of in the host. So what is their baseline CD4 count and HIV viral load? That matters because there are some regimens that are not recommended if the viral load is excessively high or the CD4 count is below 200. Very, very important to do an HLA-B5701 test because this will predict the likelihood of developing a hypersensitivity reaction to abacavir, which is one of the core nucleosides that we've been using for years. So you need that information if you're going to use that drug. What are the coexisting conditions in that person? Bone disease, renal disease. If that's a big issue for that particular patient, then maybe we don't want to use tenofovir in that patient. We should aim somewhere else. Cardiovascular disease are high risk factors. Well, there are some antiretrovirals that are associated with greater risk. I'm a viral hepatitis guy, so hepatitis B and hepatitis C are important. If they have hepatitis B, you need to remember that so that you can use medications that are active against both HIV and hepatitis B. And very importantly, you can't forget that they have hepatitis B, because if the day comes when you want to switch that regimen to something else, or you need, then you don't want to switch them from a regimen that has hepatitis B activity to one that doesn't, because then you'll see a flare-up in the hepatitis B. And you run across these scenarios from time to time where somebody just forgot about the hepatitis B. Okay? With hepatitis C, it's more an issue with drug-drug interactions with the hepatitis C medications that we use. Underlying liver disease, well, that's important as far as drug metabolism and potential for hepatotoxicity. Other infections and malignancies. Women of childbearing potential. There are some regimens that aren't fully established as being safe and sound in pregnancy, so that needs to be considered. Mental health, psychiatric illness. There are some medications, in particular the one that comes to mind is efavirenz, which used to be a workhorse, but was associated with sleep interruption and some mental health concerns. You know, if a patient's struggling with depression, that's probably not the best option for that particular individual. Substance use, well, that's for a number of concerns. Drug-drug interactions is one, with whatever recreational drug that they're using, and also the potential impact that could have on an individual's adherence. Concomitant medications, again for drug-drug interaction considerations, and for pill burden considerations as well. Food security, there's some medications that you really do need to dose with food to maximize the absorption of that medication. And we can't just assume that a person has 3 meals a day and is able to have the food there to take the medications. So we don't want to forget about that. And then potential barriers to adherence. Adherence, of course, is everything to preserving the benefits of treatment over time. Focused on the bug here, and this is a slide from one of the guidelines, BCCDC, I believe, just reminding us that it's ideal that we do a baseline genotypic assessment of every patient that we see. And this will help to help avoid starting people on medications that are unlikely to work because of existing resistance. Less of a concern for people who've never been exposed to antiretroviral therapy. A bigger concern if somebody has been on treatment and hasn't been able to successfully fully suppress their antiviral therapy. And our cases will illustrate the utility of genotyping. If genotyping isn't available or you or the patient just can't wait, Then you want to select medications that have a very high barrier to resistance. And some of these medications include the protease inhibitor Doravirine, boosted Doravirine, or one of the integrase inhibitors, dolutegravir, and I would also include Biktarvy on that list. And then the final statement there talks about selecting regimens with a high barrier to resistance, and so Biktarvy, dolutegravir, raltegravir, those two integrase inhibitors are on the list, and plus boosted Doravirine. So these are some of the considerations when selecting specific regimens, and so currently the guidelines recommend a combination of integrase inhibitor plus 2 nukes, and that can be dolutegravir plus abacavir 3-TC, or the integrase inhibitor with Biktarvy, so that includes tenofovir and imcitabine. There's also an option, according to first-line options for guidelines, that includes the integrase inhibitor dolutegravir plus 3-TC. Keeping in mind that this is where viral load matters, that if your viral load is over 500,000 copies, then that option is generally not recommended for individuals. Another first-line recommendation is the NNRTI 2-nuke combination. We've been using this approach for years, and so with Doravirine, with 3-TC and TDF, which is considered first line by the major guidelines. Other first-line alternative options can include efavirenz combined with 2 nukes, and then the protease inhibitor, boosted protease inhibitor option that remains in the guidelines is Doravirine. In some guidelines, atazanavir, boosted atazanavir plus new nukes is also on the list. We're just going to skip through these. A couple of additional considerations. We've talked about the use of abacavir. You don't want to use that because of the hypersensitivity risk unless you have an HLA-B5701 test. If it's negative, then you're good to go, and that's a great nucleoside, and it's been used for a long time, so we can be very confident about the safety. Having said that, if somebody has a high risk for cardiovascular disease, then the guidelines ask you to take that into consideration before you use it. Okay? Another additional consideration that comes up often in the clinic is the use of integrase inhibitors and tenofovir, which have been associated with weight gaining increases in multiple studies. And Shariq and I are going to talk about that issue in one of the cases to come. Tenofovir, well, it's a great drug because it's got a high barrier to resistance. It's first line for initial treatment. It's also often considered a good option in our salvage regimens. But it is associated with kidney impairment and bone disease, and the TAF formulation in those individuals is recommended, or avoiding tenofovir altogether. And again, this comes down to having a good discussion with the patient in front of you to talk about the risks and benefits as they pertain to chronic kidney and bone disease. Other considerations surrounding resistance is If that individual is previously on PrEP, then you need to ensure that you have genotyping testing, because if they failed on PrEP, they may have pre-existing resistance, which you need to know that to inform your selection for subsequent treatment. With Doravirine and the other NNRTIs, they're not effective against HIV-2, so you need to know that before you start dosing. The Doravirine has not been compared directly to integrase inhibitors. Frankly, I have no big reason to think there's any difference in the efficacy of the regimens. Doravirine has been compared with other NNRTIs and protease inhibitors and found to be non-inferior as far as its effect. With any NNRTI, there is a risk of developing resistance-associated mutations with virologic failure, so that needs to be considered if you're trying to cobble together a regimen for salvage treatment. And again, you need to know your genotype resistance before you start a person on Doravirine.
Chris, I was going to say that I think that was referring more to Doravirine.
Oh, I'm sorry.
Yep. No,
sorry.
Excuse me. I'm sure the audience caught that. But.
Yep. Okay, good. Thanks for the catching that. All right, so that is an overview of the guidelines and how we apply them to clinical practice. And now Shariq is going to talk about the really important topic of when is it best to start the therapy.
Thanks very much. And I'm going to stretch, and I'm actually going to come up here. That's okay. So let me start, first of all, by thanking Curtis. I think that was a really nice overview. And as he said, both of us have been in practice for a while. And I look at the last 10 years, and I would say there have been two major paradigm shifts when we think about initiation of antiretroviral therapy. And the first one is what Curtis actually went through, which was this big shift about 10 years ago when we decided that really HIV therapy needs to be started in our patients independent of CD4 counts. And that was actually built on a lot of very good evidence. Really well-designed randomized controlled trials, both in low, middle-income countries, certainly in middle to high-income countries. And then as well studies like HPTN 052 and the partner study, which really highlighted this importance of treatment as prevention, right? So we had robust evidence. That was the one big paradigm shift. And he did a really nice job highlighting the fact that there are treatment choices out there. And I think both of us as practitioners are going to agree that individualization of therapy still remains very important. But the second really important paradigm shift that's happened in the last, and I think this is in the last 5 years, has been this action about the timing of rapid initiation of antiretroviral therapy. And that's what my focus is going to be for the next little while. So I thought it was important just to make sure that we're on the same page around definitions. So there's really two broad definitions. There's immediate therapy, which is starting treatment on the same day of diagnosis. And I'm going to talk about certainly the evidence supporting it, but perhaps the caveats and thoughtfulness that needs to go into it. And then the second idea really is rapid initiation, which I think is what most of us are doing in our clinics, which is the idea of trying to get people onto therapy within the first, days and weeks, but hopefully within the first 2 weeks. But before we jump into that, I also want to kind of highlight a few themes from the guidelines. The left and the top is from the EACTS guidelines. And I like that because EACTS reminds us that initiation of antiretroviral therapy is not just about providing a prescription, that there needs to be some thoughtfulness that goes into it. And patients need to be ready. There is a whole staging process that goes into that readiness for treatment. There is a pre-contemplative stage, there's a contemplative stage, and we as practitioners need to support each and every one of them. And it's only after those stages that a patient says, I think I'm now ready because they've thought about this, they've analyzed themselves, the risks and benefits, and they are an engaged partner in that, in that decision going forward. And I bring that up because this idea of immediate antiretroviral therapy is built on some good evidence. And I'm going to show you some of the evidence around it. But I think we would both agree that it is certainly a big ask because it's asking you to bundle a lot of resources on that first visit. I've always said in my clinic that the easiest job in the clinic is actually the physicians. I think the success of our patients is really from everybody else in the clinic. It's our social workers, it's our nurses, it's our admin staff, and those factors really go into that decision process. Now, if we go to the top right, EX reminds us that there are barriers to that process, or the challenges to getting a patient to agree to treatment. There are a number of factors that we need to consider. Certainly, depression is a really important factor that we do see in our patients, and we need to address that before we look at the idea of starting treatment. We have an aging population, and cognitive problems are an absolute reality, and they absolutely will impact as barriers to starting treatment. And then we must recognize that sometimes concomitant alcohol use, recreational drug use, those are all factors. Now, as you can see, that the list is growing. So when we talk about bringing a patient in on the day of diagnosis and offering treatment, that is a big ask. And certainly I've been at meetings with colleagues across Canada, and the general sense is that though we are managing perhaps to meet the rapid start, I'm not sure we're all meeting the immediate start. And that's okay. I think we're going to go through perhaps that there may be some caveats to where we may want to take some time around these patients. And then I really like this. This is actually from the WHO. It's a good practice statement. And I do want to actually just go through that, if that's okay. I think this is my pointer. So it reminds us, and I know we know that, I mean, Dr. Cooper's been doing this for a long time, but I think it's important to just reemphasize, it emphasized the importance of patient-centered care. That for those of us that have been practicing for 20-some years, antiretroviral treatment is very much about engaged care. Let's not forget that patient preferences, expectations of people, the importance of dignity and respect, and particularly around vulnerable populations is really important. And that goes back to that whole staging process, that this is a process. You cannot simply bring a patient in and put them on a treatment, no matter what the evidence suggests in terms of the benefits, and we'll talk about that. So the next slide is again taken from EACTS, and I just put it up because again, I just want to reemphasize the fact that the reason the push has happened to looking at rapid or immediate treatment is all about some benefit around that's been shown in the studies around linkage and retention. But let's not forget that to go from diagnosis to linkage to retention to suppression, again, has a number of contributing factors. Important recognition, and Curtis went through this, with the drugs, they're balancing the risk-benefit of the treatment, the therapeutic indexes of the drug. Social factors, so important, we talked about on the previous slide. Let's not forget health system factors, right? Asking all this to be done on the first day or even within a couple of weeks is a huge demand. You need availability of the medication, coverage for the medication depending upon where this patient is from, provider-related factors. I think our clinic models I think are pretty similar, but I would probably say that there's still some nuances within the clinic. And in our own clinic, one of the things that we've seen post-COVID-19 is the number of new cases has substantially gone up. Now, with that rising burden of new cases, there has been a backlog within the clinic. And so again, that's those provider-related factors, and then finally, obviously, the patient-related factors. So this is a process. It's not simply about offering the treatment. So having said that, the guidelines, what are they telling us about the second paradigm shift? So they're fairly consistent. They're all recommending that it's a good idea. So DHHS says, antiretroviral therapy, initiate antiretroviral therapy immediately, the same day or as soon as possible, within days or week. And they say it's a strong recommendation. I'm going to get into that a little bit. I'm going to share some of that evidence with you from RCTs. We come to EACTS. EACTS says, I like it because I think there's some thoughtfulness. It still mentions the fact that you must assess the stage of readiness, and we went through that in the previous slides, that whole process of the pre-contemplative, contemplative stages of starting treatment. But it goes a step further and says perhaps they are considering immediate therapy in some particular subgroups, which we'd all agree, primary HIV infection. The patient has to be interested and engaged. And yes, the single most important benefit of rapid and immediate therapy is this idea of retention of care, and we'll get into that. Come to IAS, it makes an important point that, again, antiretroviral therapy should be initiated as soon as possible, so very consistent, but it highlights a clinical consideration that both of us look into, which is the issue of opportunistic infections. And I think it's absolutely true, Curtis, that there is sufficient evidence that we should initiate antiretroviral therapy early, within the first 2 weeks for OIs, but there would be probably 2 exceptions. And those 2 exceptions we must not forget. One is cryptococcal meningitis, where in fact the recommendation is to delay treatment for at least 4 to 6 weeks, and TB meningitis. And the World Health Organization says, start therapy within 7 days of HIV diagnosis. Remember the WHO, different audience, It's trying to balance, again, needs based on some of the low and middle income countries. So you're going to see differences in some of these recommendations. But overall, yes, they're all recommending that this is a good idea. Having said that, and I apologize for the next slide, it's a little busy and hard to see, but I'm going to walk you through it. It's just to share with you the evidence. And I want to highlight the fact that there is some gaps in the evidence. That the evidence suggesting that early, whether it's immediate or rapid treatment, improves retention and virological suppression is actually based on 3 randomized controlled trials, but those randomized controlled trials were done in low and middle income countries. So the first was this trial right here done in sub-Saharan Africa, and it's an unblinded randomized controlled trial. The primary endpoint was virological suppression at less than 400, and they looked at this idea of, again, rapid initiation and suggested that there was absolutely a benefit seen. We come to the next randomized controlled trial. It was actually done in Haiti. Now, I'm highlighting this because, again, differences in healthcare systems, differences in provider setups, can we extrapolate that data to middle and high income countries? I think at least we would say there's a need for us to reproduce some of that data. Was it beneficial? Yes. Again, early initiation of therapy for sure resulted in this composite endpoint of virological suppression and retention of care at 12 months, absolutely favored this idea of rapid initiation of therapy. And then there is a third, again, unblinded randomized trial out of Africa. But if we look at the evidence in the developed, in the middle to high income countries, most of that at this point, though it is evolving and it is coming, has been observational data. And I just want to share one with you, which is this one out of San Diego, California. So this was an observational study done over this period of time that's been highlighted. And they actually picked particular regimens, all integrase-based regimens. And they looked at this idea. This is just an observational study. There's no comparative arm. They looked at early, which was defined as less than 30 days from the time of diagnosis. And they were able to show that, yes, virological suppression at less than 50 copies per ml certainly, again, favored that, that concept of immediate start versus rapid. So they even looked at the idea of same day versus that first 2 weeks, and yes, there was a benefit. But this is observational data, and I don't need to convince an audience here who is a fairly esteemed research audience that observational data comes with obviously some challenges in terms of the validity and interpretation of that data. So I think that's the key point that I wanted to highlight is that yes, though those guidelines have suggested that this is a great idea, it impacts on retention, it impacts on linkage of care, we do need better evidence, and particularly in the context of middle to high income countries. I'm just going to skip the next slide. It just makes the same point. One other piece of evidence I wanted to share with you, that there is actually a Cochrane review that's been done in this in 2019. And I only want to highlight for you just, I think as clinicians, Curtis and I would probably agree, the top 3 are really important endpoints for us: mortality benefit at 12 months, virological suppression at 12 months, and retention in care. And what I wanted to highlight is they only looked at randomized controlled trials. They did not look at observational studies. And here's the important point, that though in the cases of virological suppression at 12 months, retention of care at 12 months, there's absolutely a benefit for rapid antiretroviral therapy. But look at the certainty of evidence. It's low to moderate. And there's certainly no benefit that we've demonstrated with respect to mortality. It also needs to be highlighted that all these randomized controlled trials, because you might say, well, the previous slide only showed 3 trials, but we're talking about 4 or 6 trials. Yes, there are some additional randomized controlled trials, but all of these trials from this Cochrane review are from low to middle income countries. So I again make that point that there may be room for us to look at potential areas to build on. So to summarize, rapid start of antiretroviral therapy, I would try to make the point that one size does not fit all, that there are still certain situations that do not perhaps warrant same-day start, and the big one would be TB meningitis. I just highlighted in cryptococcal meningitis, where the recommendation is, in fact, to wait 4 to 6 weeks, at least for cryptococcal meningitis for sure. And I just keep coming back to this, but the importance that this is a process. It's not simply about writing a prescription. Patient preference and motivation has to be looked into. And then I did want to highlight that there's a lot that goes on to that initiation. Rather than simply writing a script, for the patient to be ready, there needs to be patient education. There needs to be the emotional support. A lot of baseline blood testing that Curtis has already gone through needs to happen. So there's a lot of bundling, I'm going to say, of expectations and resources that needs to go into in order to actually make this happen. I would also highlight that there are some research gaps that exist in rapid antiretroviral therapy. I still think that there is, I think, and certainly others would agree as well, that there's certainly some role for us to expand further implementation science to assess the adaptations of healthcare systems. Yes, we have demonstrated in randomized controlled trials in low to middle income countries that if we start treatment early, we improve retention. At 12 months, perhaps we need to look beyond 12 months. Is that effect carried out? So I think there's certainly the need to do that. Again, further research on the impact on long-term outcomes I think is going to be important. I did want to also highlight that much of that data is in adults. So research on children and adolescents on implementation of rapid ARV therapy is still a gap. And we must remember that there are additional, I'm going to say, challenges perhaps, or nuances. Disclosure of HIV status, a much bigger issue perhaps. And again, dosing. I'm not a pediatrician, but certainly there are significant nuances that go into it. I'm going to make sure that we're right there. I did sort of add this, that though I know that we have some existing data around early start of antiretroviral therapy and TB, I still think that there is room to build on that evidence, because this idea, excluding meningitis, that are we doing the right thing by starting treatment early, trying to balance that risk-benefit ratio. So I think these are opportunities for us, certainly in the research arena, to build on this area. Now, that brings to us the end of our journey about starting therapy. But I'm sure if I ask Curtis, he's going to say that we spend a lot of our time in our clinics, because a lot of us have treatment experienced patients, because we've been around and doing this for a while, with this concept of that next phase, optimizing therapy. And some people, categorization of sort of switching ARV therapy. So are there guidelines? Absolutely. I think the first most important thing is that we come to an agreement about what is the context of optimization. Well, it is always in the context, in most cases, of virologically suppressed patients, right? So the idea is these patients must be suppressed with a viral load less than 50 for at least 6 months. And then here are the indications, and I'm sure Curtis is going to agree with me that this is what we see day to day. Sometimes we make optimization because we're dealing with an existing side effect with a treatment, and we need to optimize the treatment to get around that side effect. But a lot of the times it's anticipatory, right? It's about looking down the road and saying, you know what, I see a potential downstream long-term toxicity, and I want to optimize the therapy today. Curtis spoke about drug-drug interaction issues, huge issue in our clinics. As our patients are getting older, polypharmacy, that's a good reason. Pregnancy, absolutely, there needs to be adjustments of medications based on the guidelines. Aging, very important piece. I've been doing this for over a couple of decades, have a pretty treatment experienced population. My oldest patient, I can tell you, is 92 in my clinic. And so this just tells you that aging is absolutely really important. I have a HIV fellow in my clinic, and we spend lots of our time talking about aging and its impact and the nuances that go into it. But I want to come simplification to reduce pill burden. I'm not going to touch on hepatitis B. Curtis has already spoken about that. But I wanted to touch on this point, regimen fortification. We do a lot of that, Curtis, right? I think that's a big part of it. We have a patient, they've been doing well, they're virologically suppressed. The one really positive thing that's happened is, and the next few years it's going to continue hopefully to evolve, is that we're now getting drugs with much wider therapeutic indexes. And so we have that ability now to say, listen, I think there's opportunities to fortify this regimen because we're concerned that perhaps down the road we're going to see virological breakthrough because of resistance issues and so forth. Cost obviously is always a consideration. So a case. So this is a patient of mine, a 54-year-old Caucasian female, was diagnosed HIV positive in June 2020. Actually, the initial presentation was to a hematologist. She was being worked up for thrombocytopenia. They were dealing with what they thought was immune thrombocytopenia, and subsequently the diagnosis of HIV was made. Her past history was LSIL, HSIL on Pap smears, history of depression, alcohol use, GERD, and some sleep apnea. Baseline CD4 count was 280 or 17% cells per cubic millimeter, viral load of just under 40,000. And the patient was started on Biktarvy in July of 2020. And I show you that the baseline weight was 74.4 kilograms. Patient did very well. Within a few months, by October, the patient was virologically suppressed, and the CD4 counts were quite reasonable, up to about 500. Very pleased with that. Fully compliant on treatment, but there was this issue of progressive weight gain. And I want to walk you through the timeline. So we started here with Biktarvy therapy, and absolutely we saw about a 3 kilogram pickup, and all of us know, data from certainly our own experience, published data, the two big studies being ADVANCE and then the SACS analysis looking at the impact of weight gain with integrase inhibitors, that we must remember that there is an expected return to health. There is always going to be some weight gain as you initiate antiretroviral therapy. So that was no concern. But October 2021, we've now gone from 74 to 87 kilograms, and lifestyle modifications were instituted. And then by May 2022, we're still up another kilogram or two. Now, these decisions about making changes are not just us. You have to sit down with your patient, as Curtis said, right? It's a discussion, and we've all done that post-COVID. Everybody gained weight. I gained weight. We all did. But the reality is you have to sit down with that patient and say, okay, from your perspective, is the weight gain a lifestyle issue? Is it a sedentary lifestyle? Is it diet-driven? And we went through that with this patient, and she's a very engaged patient and said, no, I've done everything right. I'm concerned. I think when the patient says, I am concerned, your hand is moved. You need to do something about it. And as we said, there are some signals that are there. So we made a decision May 2022 to switch this patient to Delstrigo. And what happened after the switch? Well, a year later, the weight plateaued. So 88 prior to the switch, 1 year later on Delstrigo, 87.8. Now, before I'm going to ask Curtis his experience, I want to share with you that I made our clinic pull out. We have multiple practitioners. These are not all my patients, but I pulled out all the patients in our clinic who were switched from Biktarvy to Doravirine. And just to show you kind of what I did is we've highlighted the ages. We've highlighted, obviously, gender status, because as you do recall from the ADVANCE study and the SACS analysis, there was this signal certainly suggesting that women, particularly African Black women, were much more likely to have more significant weight gain. But as you can see here, that wasn't necessarily the case in the experience here, but I just want to walk you through them. So this was the case I already shared with you. I'm showing you the weight at the switch, the baseline weight. This is the delta difference that happened. And this was if we had follow-up weights after the switch. So you saw the plateauing effect in that case. The second was a 51-year-old female from Zimbabwe. Baseline weight was 64.5 kilograms. The delta was 14.5 kilograms in 2 years. So if you remember, from all the discussions we've had around weight gain and integrases, I think this is still an area of great controversy, right? The data is definitely discordant. We all know that if you look at outside of the HIV arena and you look at weight gain in the general population, we say 1 kilogram per year. Perhaps that needs to be modified during COVID, but at least 1 kilogram a year. If you looked at the initial studies that were done, the initial sort of analysis done by Sachs, where he looked at those 8 randomized controlled trials in naive patients, the median weight gain was actually 2 kilograms over 2 years. So, what would be considered concerning weight gain? And I think some of us would say, I think, and the data would suggest that perhaps greater than 10% at baseline is a reasonable value. So this was 14.5 kilograms. The change was made here, and post switch to Delstrigo, 72.5. So we actually did get a regression of weight. Is this a Doravirine effect? Who knows? But we did see an effect. The only one I'm going to say that I personally, this is not my patient, and I think this is probably the outlier here, because these were all patients who were naive, started on Biktarvy, got switched to Doravirine. This was actually a treatment experienced patient. So this was a patient from Zimbabwe who had previously been on ARV therapy, PI exposures, as you can see here, Combivir and Alfinavir, then boosted Dorinavir, and then stopped treatment in 2016 when she re-engaged in healthcare. And at that time, her baseline weight was 63 kilograms, and her weight at the switch when it happened was 80.3 kilograms, and this is over 2 years. Now, the reason I say this is an outlier is I think some of us would say that patient is very different, because by the time they came back to care, if they'd been off treatment for 6 years, these patients likely were quite advanced with respect to disease, and we know from the SACS analysis that the group that had the most significant driver of greater than 10% difference in your baseline weight was in fact low CD4 counts. So perhaps this one I may not look at, but it was done. I don't have a follow-up weight for you. I just want to highlight that not all these were women. So 38-year-old male, Caucasian, yes. Now here, this patient was already overweight, right, to begin with at baseline. But again, the weight this is significant, 43 kilograms. And this is over a period of, I'm going to say, just over a year. The effect of the change is that, yes, we're seeing some regression, 157.2 kilograms. And then finally, a 55-year-old male, and you're seeing, again, baseline weight of 114, so overweight at baseline. 124 at the time a decision was made, which is a 10-kilogram delta difference to say we should make a change. In this case, there was no effect, right? So if you look at all these cases, you would say, two things I think I would say. One is, I think none of us would agree that some of these weight changes are significant. I mean, it's very difficult as a frontline practitioner to walk away from this. The second thing I would say is that these cases highlight, I guess, two questions, Curtis, right? The first question that we're all dealing with is, is there a signal with the integrase inhibitors, right? That's certainly the first question. And the second question, which is an equally unanswered question, is in those patients, if you believe the fact that there is a signal, is switching them to Delstrigo result in a meaningful difference in weight gain over time? So I was just more curious, Curtis, your experience with integrase inhibitors in your clinic. Have you seen cases of weight gain? And perhaps the second part, if you've done it, have you had cases where you've made the switch?
Sure. So just a couple of thoughts. The first is that with every single antiretroviral that we have to consider, if you went through all the potential complications, we wouldn't use anything. This one has cardiovascular risk, this one has renal risk. And I think we really need to keep in mind and in our education efforts, remind people that these are important considerations, but they're very, very rare. And so we don't want to throw out really good drugs from the conversation because of rare events. The other comment I'd like to make is, at least in my clinic, and I talk to my colleagues, it's the same story. We've seen this phenomenon long before there was such a thing as integrase inhibitors, long before there was tenofovir. There are individuals, for reasons I don't fully understand, who go on antiretroviral therapy and they gain a lot of weight. We've seen that before with protease inhibitor-based regimens. And yes, I absolutely have seen this with a number of my patients on our current modern regimens that are integrase inhibitor and or contain tenofovir. This is where it's so key to understand your patient and what their concerns and fears are. Many of my patients are very educated about the options available to them when they first arrive in clinic. So, if the person in front of me says, "Look, I don't want to gain a ton of weight on these treatments," if that's like a core consideration, if I turn around and put that person on a treatment that is a risk, that's going to erode trust and confidence. So, half my job is to convince somebody that I can help them, and then the second half of my job is to help them. So you need to work with the person and find a regimen that they're comfortable with. If it's somebody who has underlying cardiovascular disease, then okay, well maybe I'm going to avoid treatments that have any of those concerns. So we have lots of patients on integrase inhibitors. Most don't run into this issue. Some do. Then we talk about the options. Diet, exercise, and weight management that's a brainstem comment that comes from me with every patient that I see. We don't always, the pharmaceutical route is not always the first one to go with. It's lifestyle stuff that needs to be considered. Doravirine has not been associated with this phenomenon. So if somebody's really concerned about it, or if they're experiencing that, then I think it makes sense to switch to what is a good regimen that's first line. I think the data is currently lacking as to whether that's going to result in a stop and reversal of the phenomenon. So that's a research gap that we should address.
Perfect. No, excellent. And I think I would entirely echo the exact same assessment of our patients, or the plan that we put in place is exactly what you said. We always look at lifestyle modifications. But I highlighted these cases to say that at some point, you have to do something. These are very rare cases, but when they happen, the exceptional weight gain that we're seeing does move you to doing things. The thing I want to highlight is that there is, what we're waiting for is that research gap, that there is a clinical trial. Just wanted to highlight that that's underway. ACTG is involved. It's called the Do-IT trial, which is a randomized controlled trial that's going to be taking patients who are on an integrase-based regimen, virologically suppressed, who've had weight gain, and the trial will be randomizing patients to either continuing therapy on that integrase-based regimen or switching to Delstrigo. We'll finally have some randomized control data to answer the question that does this actual switch that we're doing have a meaningful difference. So that's important. I think that's a really important step going forward in this question. Okay, just in the interest of time, I'm not going to spend a lot of time just to tell you that yes, there are some broad recommendations around optimization that exist through the guidelines. This is just from the DHS, NIH. I only want to highlight just two little points here, the point number 2 and point number 4. So point number 2 highlights this fact that, again, optimization needs to be done with thoughtfulness. You don't want to make a change and jeopardize future treatment options. This is still something that requires a lot of due consideration. And then the last bit, that these are the elements you must look into. That in the cases of optimization, whether it's done for the issues of weight gain, et cetera, look at the patient's prior virological responses, past toxicities, intolerances, and absolutely the resistance data. So there is a complexity involved even in the process of optimization. Just some specifics from the DHS guidelines that if you already have NRTI resistance at baseline, the recommendation is that you should put 2 NRTIs in the backbone and a third drug with a high resistance barrier, dolutegravir, boostedurnavir, or bictegravir. And this is going to become a really important one. I think actually Curtis did touch on that, as we move forward with potentially use of cabotegravir, rilpivirine, I think there are going to be some nuances that are going to come in. So if you have patients who are pregnant on cabotegravir, rilpivirine, obviously the recommendation is about looking at an alternative regimen based on the perinatal guidelines. But the other bit would be that if you've had, if we move to a PrEP sort of context and a patient comes in who's been on cabotegravir, rilpivirine, now the importance of getting baseline integrase resistance is going to be important. So here's another element that may be a barrier to that immediate and rapid initiation of antiretroviral therapy that we talked about a little bit earlier in the talk. Hepatitis B, Curtis has touched on, so I won't go into that. I will put this up because it tells us that me and Curtis still have a job and will remain employed. So this is selfishly being done, that it makes the point that consultation with an HIV specialist is recommended when you're thinking about optimization, particularly with a history of resistance to one or more classes, which are a lot of the patients that he and I share have in our clinics. And close monitoring is still necessary after you make the switch, looking at suppression, adherence, and safety. Generally 3 months after the switch is the recommendation. I'm not going to go into this. This is actually more just for you to know that the BC guidelines, I agree with Curtis on that, they're very pragmatic. So they go into a little bit of specifics. They speak about the fact that there's opportunities for trying to optimize therapy. Most of it has to do with trying to mitigate long-term side effects. TDF to TAF is an easy one to mitigate the issue of bone and the issue of renal toxicity. The idea of just the bottom one here, switching from ritonavir to a cobistat-based regimen, again, trying to minimize the whole DDI, drug-to-drug interaction issue. So these are thematic recommendations. I think one that I wanted to highlight, because we do a lot of this, because I have a treatment-experienced population, finally, thanks to newer medications with wider therapeutic indexes, this idea of boosted PIs, and I'm sure, Curtis, you're looking at that as well. We're always worried about the metabolic long-term effects as our patients are getting older. And switch from that to integrases and perhaps even to some of the newer classes is certainly an area of great focus within our clinics. I'm just going to skip this and turn it over to Curtis to talk to us about salvage. I'll bring this over here, actually.
All right, great.
Thank you.
Thanks, Shariq. So we are getting towards the end, so I'm not going to spend a ton of time on this case. I'd like to leave a couple minutes for questions if there's anybody that wants to do that. And I definitely don't want to bleed into the plenary session at 9. We're all very excited to hear from our colleague Jean-Pierre Routy, so don't want to ruin that. So I'm briefly going to talk about a salvage case. Thankfully, I seem to run into much fewer salvage cases than I did back in the bad old days when our antiretrovirals were pretty horrible, and there was a large segment of our patients that just they weren't working for them. So this is a 55-year-old male diagnosed long ago, most recently on raltegravir and Kyvexa. His adherence is 50-50. It kind of depends on the week and depends on the month. And there's been years of efforts trying to support and reinforce the importance of adherence, but it's just not happening. And you can see that the viral load has been creeping upwards and the CD4 count has been declining over time. From the history, and this is sometimes a bit of detective work, there's previous experience on AZT, stavudine, DDI, indinavir, and efavirenz. There's also issues with polysubstance use, which goes a long way to understanding why there's the struggles with adherence. So the guidelines remind us that these are complex, challenging cases. You need to look into why people may not be successful on their regimen, which include adherence, drug-drug interactions, absorption, tolerance of the medications. I think that's an obvious one. What their baseline viral loads and CD4 cell counts were, and their history of ARV treatment. Also key, you need the aid of genotypic evaluation, and it's best done within the first 4 weeks of being on that regimen. If the person's already stopped them, then in many cases the majority of virus reverts to wild type, and you won't identify the resistance-associated mutations that you're looking for. As a general practice, if I know somebody has previously been on a regimen that wasn't working, I almost assume that they have those resistance mutations, even if they're not identified on the assay. So we did an evaluation. The person has most recently been on a integrase inhibitor regimen, so raltegravir, and he has a key mutation, the 155H. Which confers resistance. We still have dolutegravir and bictegravir, which have a higher threshold to resistance, to at least consider in cobbling together a new regimen. There was a 184V, that's a famous resistance mutation for lamivudine, but also predicts enhanced susceptibility to some options, including a high threshold medication like tenofovir. With the NNRTIs, I was sort of curious that this 138Q came up, and I said, well, you don't really typically get that with efavirenz. So crawled into the caves of the Ottawa hospital looking for the old records, and sure enough, this person had a past exposure to rilpivirine about 15 years ago, and that's probably where that mutation came from. And then with the PIs, no recent use, so even though it says susceptible for indinavir, I wonder whether that's an option. But darunavir, boosted darunavir, given its high barrier to resistance, is a consideration. So we're just going to go over these, except the principle is when you're trying to create a new regimen, you need at least 2 drugs, or if you can find them, that are still active. And you need to try and choose drugs that have high barriers to resistance. In this case, we included darunavir, boosted darunavir, so plus tenofovir as part of Delstrigo, which has darunavir, and we were fairly confident that darunavir would be effective in somebody who previously was unsuccessful with efavirenz, given the resistance profile that this person had. Changing the drugs is obviously not enough. I know I don't have to tell anybody in this room that. We continued our discussion with adherence. I did, our pharmacists, our social worker, tried to support that over time, tried to engage the individual in harm reduction activities for the substance use. And initially there was success. The viral load was less than 20. Then in the fall, treated the patient for syphilis and gonorrhea, so sort of started to raise some concerns. And then we saw a bit of an increase in the viral load in February. So I think the story remains to be told with this. Before we wrap up, I guess I'll just ask Shariq, any other, how have you approached the case, and what have you used, any other, we didn't include an integrase inhibitor in this.
Right.
I think that could have been part of the solution.
Yeah, and I think that probably is the only question, and I'm sure the reasons why it wasn't done is that 155H, yes, we had some options with dolutegravir and bictegravir, with dolutegravir specifically, but it would have been BID dosing, and I'm assuming this gentleman who's had some adherence concerns, we're trying to build sort of a once-a-day regimen. Sometimes I think the other thing to highlight, sometimes I think we do see with 155H, though yes, dolutegravir can work, but if you happen to have that K156 polymorphism at baseline, you can render resistance, so that might have been also a reason not to. So I think dolutegravir, that's the only question that would have come up to me at that stage. But as I look at the blip that's happened now in February 2023, what would I do at this stage? I'm sure you would do the same thing. We bring these patients back. I think we need to sort out at this point now, what's the adherence like? If we're convinced that this is an adherence issue, then really you don't want to be losing other classes until you address the adherence concerns. But if, on the other hand, the patient is fairly convincing to you that the adherence is not an issue, then everything Curtis said was absolutely correct. The guidelines recommend that you have at least 2 fully viable drugs. But again, the question again becomes, does this patient actually need fortification? I think the answer would be yes in that case. And then I would personally, at this point, thanks to the newer options that are out there, actually think about lenacapavir. That really is the direction I would probably go in. Again, because that would balance out the concerns about adherence, so sort of directly observed therapy, under our care, and we get this third full drug to try to maintain virological suppression. But a very challenging scenario.
Yep. Thankfully, because of the quality of the meds we have these days and our wraparound efforts, we see these cases less frequently. So, a couple of concluding statements. There's many factors that contribute to treatment success. We have many, many great options to choose from. Thank goodness for that. Achieving success with the first regimen can sometimes be as complex as subsequent attempts, just because of the complexity of human beings. And an approach focused on the specific needs of the individual can improve the likelihood of long-term success. So I'd like to thank CAHR for asking us to present this morning. I'd like to, again, to thank Merck for their support. I'd really like to thank you for all getting up early and joining us. We do have a couple of minutes for questions or comments, if you have any. Then we'll wrap it up and get ready for the next symposium at 9 in the morning. Hi there.
Hi, thanks very much. That was great. Really good overview. I'm one of the people that is called a patient. I don't feel like a patient most of the time. I feel like someone who has my own voice. But there are times when that voice disappears. And the voice disappeared when I was first diagnosed. So one of the things that I would suggest about starting treatment right away is recognizing that someone only hears, you have HIV. And in the day that I heard it, it was you have AIDS. Like it's a big message right from the very beginning. And somebody has to be able to take that in and deal with that before they can go and start taking any kind of good medicine for that. So that's one thing. The other thing that I have to say is I did a lot of volunteer work in Africa, and there people are so unsure that they will ever have an opportunity to get medication that they would sign up for studies if that guaranteed that they would get medication. So I think that the results from Africa need to be balanced with that kind of a personal choice that people have to make. But again, I thank you for that incredible overview. There are so many more options out there now than there ever were before. And if people want to, there's a timeline over there in the room next door where there are the posters that looks at HIV from 1980 to 2022. And there's huge changes that have happened to what's available for people, what kind of advocacy is needed. And I think it is really, really important that people like me, who are the receivers of the benefits of this research, have an opportunity to share.
Thank you for your words. That was great. So both Shariq and I have like a million years of university education. They used to call me the perma fellow. But in truth, our education continues to this day. And as I've matured, as I've got smartened up, and I listen and allow myself to be educated with what my patients are telling me. So thank you for helping to make us better physicians. Okay, I think that was it. Oh, sure, we'll take one more question.
For this great update. I have a question in regards to guidelines in pregnancy, particularly after the signal that we all know about from 2018 of increased neural tube defects in pregnant women receiving dolutegravir in Botswana, and what has that resulted into in terms of availability of antiretroviral drugs, particularly in Africa, related to the comment that we just heard. Can you provide us a bit of an update? Where are we at with dolutegravir recommendation during pregnancy? Thank you.
Do you want to I can feel. Thank you for that question. Actually, I just wanted to follow up on the original comment. I wanted to again thank the.
Do it in a minute.
Oh, okay, I will do it in a minute, I was told. So I'll do it very quickly. Just wanted to thank the original speaker for that exceptionally thoughtful comment, and we totally agree. Around the Botswana registry, I think the good news is that that registry data has been carried forward. That signal that was initially being seen appears again at this point not to be as causal. So certainly even if you look at the WHO guidelines, first-line therapy that's actually recommended right now in the WHO guidelines is actually a dolutegravir-based regimen. So I think, do we still have that discussion? I still do. I'll turn it over to Curtis and ask. I still bring it up. I still have that discussion with the patients, but from my clinical lens and my interpretation of the data and what I know about the registry, I think it is becoming certainly less of a concern, but I still do highlight that in the discussions that I have with the patient. I don't know, Curtis, what you're...
Yeah, absolutely. You don't want a person to come back a couple months later and say, well, you didn't talk about this. And I think a big point is our job is to provide information and try and help with the interpretation. So yeah, it's something that should be discussed, but the literature at this point suggests that it's less of a concern, and I would feel comfortable using that or recommending that medication to a woman of childbearing potential. Okay. So again, thank you very much for joining us today. I hope you found it of some value, and we look forward to the next session to come. Thank you.
Thank you.